Greetings, I am Alice Ringo, a third-year Doctor of Pharmacy candidate from Pensacola, Florida, and today I will be presenting my journal club on empagliflozin, cardiovascular outcomes and mortality in type 2 diabetes. The authors of this article include several medical doctors, Bernard Zinman, Christoph Wanner, and John M. LeChan, funded by the Bollinger Ingelheim and Eli Lilly. The drug empagliflozin, also called Jardiance, is an SGLT2 inhibitor that is used to treat patients in type 2 diabetes. This class of medications will lead to a reduction in blood glucose levels, which thus can in turn increase glucose excretion. The objective of this trial was to test to see if empagliflozin, along with proper diet and exercise and care, could have a positive benefit to patients with type 2 diabetes mellitus, who are at an increased cardiovascular morbidity and mortality risk. The trial design included a double-blinded trial, so neither side knew which drug got the actual drug and which one got the placebo medication, a placebo-controlled trial. It was also randomized and multi-centered, and this trial took place in 590 sites at 42 countries. So this trial was very broad and included a wide range of different cultures and aspects of people. The IRB approval for this trial, they made sure that they got written information, written informed consent before study entry. All the authors vouched for the accuracy and completeness of the data analysis and for the fidelity of the study to the protocol. And an independent ethics committee or institutional review board approved the clinical profile at each participating center. The inclusion for this criteria included type 2 diabetes mellitus patients over the age of 18 years old, patients with a BMI of less than 45, patients with cardiovascular disease, patients who have had a heart attack within the previous 2 months, patients that have multi-vessel or single-vessel cardiovascular disease with positive stress tests, patients that had a stroke within the past 2 months, and patients that are on no glucose-lowering agents in prior 12 weeks and with the A1C level between 7 and 9. And they were also looking for patients with a stable glucose level of 7 to 10 in prior 12 weeks. The exclusion for this trial included people with uncontrolled hyperglycemia with a fasting glucose of greater than 240, patients with liver disease with ALT, AST, or ALP, planned cardiovascular surgery or angioplasty within 3 months, prior surgery with chronic malabsorption in the past 2 years, patients that have cancer, patients that are taking anti-obesity drug treatment within the past 3 months, patients that had a change in thyroid hormone dosage in prior 6 months, and also very important, nursing pregnant or childbearing age women or that are on birth control or refuse to take a pregnancy test before the initiation of the trial, or patients that have alcohol or drug abuse. The subjects on this trial were mainly adults that had previously type 2 diabetes mellitus who were at an increased risk for cardiovascular events. The primary goal of this trial was to see if empagliflozin could reduce cardiovascular mortality, non-fatal myocardial infarction, or non-fatal stroke. Along with this, to reduce the hospitalization for unstable angina or stable angina. For the patients that were participating in the trial, they were told they had to follow up and attend a clinic at a specified time or follow-up visit 30 days after the treatment has ended. Or the data regarding safety was reviewed 3 months at the discretion of the committee. This trial took approximately 3.1 years and had a total of 7,020 patients that participated in the trial. Empagliflozin was given to the patients in 2 different doses. 2,345 of the patients received a 10 milligram dose once daily, and 2,342 of the patients received a 25 milligram dose once daily, and 2,333 patients received the placebo drug. The arms for this trial included patients were in a randomized group with a ratio of 1 to 1 to 1, with stratification by the A1C, BMI, renal function, and the geographical regions. There were only 3 options available: empagliflozin 10 milligrams, empagliflozin 25 milligrams, and a placebo. And the trial was randomized, so every patient was given one at random. The doses were taken after a 2-week open-label placebo run-in period, and they also took into consideration patients that had other cardiovascular risk factors such as dyslipidemia and hypertension, and they were treated at the discretion of the local guidelines by the conductors of the trial. The statistical analysis for this trial included using a modified intention to treat with the patients who had received at least one dose of a study drug. Secondary analysis included comparisons of the 10 milligram dose of empagliflozin versus the placebo and the 25 milligram dose of empagliflozin versus the placebo. Also, the study was designed to first test for non-inferiority and then for superiority. The baseline characteristics that they needed for this trial was the demographics with the average age of 63 years, 29% of them being female, with 73% of the participants being white, 22% being Asian, and 5% black. The geographical regions included 41% taking place in Europe, 20% in North America, and Asia with 19%. The health measurements, an average of patients with a BMI of 31 and a blood pressure of 137/77. The laboratory values were patients with an average A1C level of 8.1 and a glomerular filtration rate of 74. Past medical history include cardiovascular disease, which was 76% of the patients, single vessel being 11%, and anti-vessel being 47%. And a myocardial infarction, 47%. Patients that had received CABG was 25%, stroke 23%, and heart failure in 10% of the patients. And also very important, patients that had previously been diagnosed with type 2 diabetes mellitus. It was 3% of patients that hadn't been diagnosed a whole year yet, 15% for patients that had been diagnosed 1 to 5 years, 25% for patients that had been diagnosed 25 to 10 years, and 57% for patients that had been diagnosed for 10 years. Their only glucose-related medications were, the majority of the patients were receiving metformin plus insulin at 45%, metformin plus a sulfonylurea at 43%, and monotherapy at baseline with 29%, with 36 receiving just metformin and 46 receiving just insulin. The primary endpoint of this trial concluded that 490 of 4,687 patients in the pooled empagliflozin group and 282 of the 2,333 patients in the placebo group. The HR was 0.86, so there was a 14% reduction risk in the pooled empagliflozin group compared to the placebo group. The secondary endpoints in this trial concluded that empagliflozin resulted in a 32% reduced risk of all-cause mortality. The risk of cardiovascular death was reduced by 38% with empagliflozin treatment. There was no significant difference in the risk of non-fatal heart attack or non-fatal stroke when it comes to cardiovascular mortality. And heart failure hospitalization had a 35% reduced risk of heart failure with patients taking empagliflozin versus the patients taking the placebo drug. It is also important to note that both doses of the medication were associated with about 2 kilograms of weight loss during the follow-up, because all drugs, the majority of the drugs in the gliflozin class can cause a reduction in body weight by enhancing glycemic control. Also, both doses were associated with about 4 millimoles of mercury reduction in systolic blood pressure during the follow-up. With the adverse effects that was associated with this trial, only 23.5% were severe and 38.2% were serious, and only 3.8% death in this trial. So there was leading to discontinuation with 17.3%, hypoglycemia 27.6%, 18% of patients received a UTI, and only 1.7% had a complicated UTI. There was 6.4% that had a genital infection. The conclusion by the author of this trial was that the patients that had previously been diagnosed with type 2 diabetes mellitus who had received empagliflozin had lower rates of death along with lower rates of composite cardiovascular outcome from any cause than those in the placebo group when the trial was added to standard care. The strengths of this trial included the fact that the trial is a double-blinded study that kind of took out some of the room for bias, because neither side knew who got the treatment drug or who got the placebo drug. There was a wide geographic region, so they were able to take into account the different cultures and what's going on in each different country respectively. A respectable number of patient involvement with over 7,000 patients participating in the trial. a multi-center research randomized trial. The only weakness of the trial was the p-value for the primary outcome was not high enough to prove superiority based off of a single trial. So basically, to summarize this whole article, the purpose of this trial was to see if empagliflozin would be superior to a placebo drug in improving glycemic control and lowering cardiovascular events in patients with type 2 diabetes mellitus and cardiovascular disease. Empagliflozin is a very good drug for treating type 2 diabetes mellitus and is an SGLT2 inhibitor, so it works to reduce hyperglycemia and increase glucose excretion. The FDA requires that the new antibiotic drugs meet their criteria to demonstrate cardiovascular safety. Following the widely publicized cardiovascular safety concerns with rosiglitazone, the FDA mandated that all new diabetic drugs conduct studies demonstrating cardiovascular safety. The upper limit of the 95% confidence interval for the hazard ratio had to be less than 1.8 for pre-marketing studies and 1.3 for post-marketing studies. This trial thus establishes the cardiovascular safety profile of empagliflozin for use in patients with type 2 diabetes mellitus. To conclude, the results of this trial goes to show that empagliflozin will be effective in lowering glucose levels and will also lower the risk for cardiovascular death and hospitalization from heart failure. This is an added benefit with this drug, which is not in other diabetic medications in other classes. The only issue that this drug could present would be cost, but in establishing risk versus benefit, it may be deemed essential in certain patients. I personally feel like this drug will be a very good one to be used in practice, since the results of the trial said that it had an increased risk for for helping to reduce cardiovascular mortality and morbidity in patients with already uncontrolled type 2 diabetes mellitus. Again, my name is Alice Ringo, and this is the conclusion of my journal club. Thank you, and enjoy the rest of your day.